Pressure ICP Oxford and Julian. 1. Normal ICP. 5 negative 15 mmHg. 2. Compensatory mechanisms maintain ICP until overwhelmed. 3. ICP rises steeply with small increases in volume once mechanisms fail. 4. Slow-growing lesions, large volume before significant ICP rise. 5. Fast-growing lesions, small volume can cause significant ICP rise. What is normal intracranial pressure? Around 10 mmHg or less. Sustained pressure of 15 mmHg is termed. The contents of the cranium are not. Hypertension, area. Sustained pressure of 15 mmHg is termed. The contents of the cranium are not. Of focal ischemia if ICP, 20 global ischemia if ICP, 50, treatment usually considered if ICP, 20. What are the causes of raised intracranial pressure? According to the Monro-Kelly hypothesis, the contents of the cranium are not compressible. Any significant increase in the volume of brain tissue, blood or CSF within the cranium will lead to a rapid rise in intracranial pressure ICP. 1. Increased brain volume, cerebral edema, swelling. 2. Mass effect, space-occupying lesion, hematoma, tumor, abscess. 3. Increased CSF volume, hydrocephalus, meningeal inflammation. 4. Increased blood volume, increased CBF, hypoxia, hypercapnia, increased cerebral venous volume, increased thoracic pressure, venous obstruction, cerebral perfusion pressure CPP. 1. CPP equals MAP ICP. 2. Autoregulation maintains constant CBF despite changes in MAP. Normal CPP equals 80-100 mmHg. Remember that adequate tissue perfusion is not just a function of CPP but depends on blood flow and oxygen content. Cerebral blood flow CBF. Autoregulation. 1. Maintains CBF 50 ml/100 g min, between MAP 60-150 mmHg. 2. Impaired and chronic hypertension, acidosis, hypoxia, hypercapnia, and head injury, factors affecting CBF. 1. Metabolism, determined by brain demands. 2. CO2 tension, hypocapnia decreases CBF. 3. 0-2 tension, vasodilation occurs only at PaO2 is less than 7 kPa, 53 mmHg. 4. Temperature, decreased metabolism and CBF with hypothermia. 5. Viscosity, increased CBF with reduced viscosity HCT, 309%. 6. Anesthetic agents, how can you measure intracranial pressure clinically? There are 4 methods commonly used via the skull in a lumbar approach via a CSF catheter. 1. Epidural catheter, strain gauge transducer at tip or fiber optically supplied light reflecting off a pressure-sensitive membrane. 2. Subdural bolt or catheter, prone to blocking and leak but less risk of infection than ventricular catheter. 3. Ventricular catheter, gold standard, accurate, CSF can be drained but risk off infection. 4. Intraparenchymal catheter, light-reflecting pressure-sensitive membrane and are most commonly used. Lundberg waves, A waves, sustained pressure waves, 60-80 mmHg, every 5 to 20 minutes. Life-threatening and represent cerebral vasodilatation in response to JCPP. Need urgent treatment. B waves, small and short-lasting waves, 10-20 mmHg, every 30-120 seconds. Caused by fluctuations in CBV, C waves, small oscillations, 0-10 mmHg, reflect changes in systemic arterial pressure, anesthesia in presence of raised intracranial pressure, symptoms and signs. 1. Early, headache, vomiting, seizures, focal neurology, papilloedema. 2. Late, hypertension, bradycardia, agitation, coma, pupillary dilatation. Management aims. 1. Avoid increasing ICP. 2. Maintain CPP 60-70 mmHg. 3. Prevent cerebral edema. Specific measures to decrease ICP. 1. Osmotic or loop diuretics Manadol, furosemide. 2. Modest hyperventilation PaCO2 4.0 to 4.5 kPa. 3. Corticosteroids, for tumors and abscesses. 4. CSF drainage. 5. Head-up tilt, 30 degrees, to reduce CVP, anesthetic agents and intracranial pressure, volatile agents. 1. Increase CBF and ICP. 2. Reduce cerebral metabolism. 3. Abolish autoregulation. 4. Halothane increases ICP most, isoflurane least, IV anesthetic agents. 1. Decrease cerebral metabolism, CBE, and ICP. 2. Exception, ketamine increases ICP, other drugs. 1. Succinylcholine increases ICP muscle fasciculation. 2. Opioid analgesics, little effect on CBF and ICP if normocapnia maintained.